Hi everyone, and good afternoon, and welcome to the first lecture of our analytical chemistry series. So my name is Dr. Matthew Waite, and I'm one of the registrars in chemical pathology and metabolic medicine here at Imperial. So if my slides work. This lecture series was born of really of a desire to give new ST3s in chemical pathology a crash course on laboratory medicine. And so it was designed for specialist registrars, but I'm sort of sure and happy that it's of interest more widely as well. So we might not have all of the answers, but we'll hopefully offer a good introduction throughout the whole set of lectures. If you have any questions or you spot any corrections or you have any feedback at all or anything else that you think we should be covering in this series, then please feel free to email me. My email address is there. So just to start, laboratory theory in essence is about using laboratory analysis to support clinical care. And for most of us specialist trainees, our training up to this point has really been focused on clinical care and much less so on the role of the laboratory. So in clinical testing, we've got three must-haves. The first is a sensible question. The second is sensible interpretation of results. And the third is a result that is correct. Now, A and B are very familiar to us in clinical medicine, but all three of these can lead to inappropriate further testing or referral or treatment or even inaction. And all of those can be harmful for patients, but they also all have time, financial, and service implications. Now, what is a correct result? And I don't think there's necessarily an easy answer to that question. But if we keep it patient-focused, a correct result is one that can be relied upon in relation to the management of a patient. And to produce a correct result, we need to focus on three key areas: pre-analytical, analytical, and post-analytical. We also need to remember that decisions to utilize tests or their interpretation occurs outside the lab, but there is still some involvement. For example, someone in a lab tends to approve expensive tests or tests that need to be referred to other sites around the country to be performed. And some lab tests aren't reported as numerical or raw results and are instead reported as an interpretation, protein electrophoresis being the best example of this. So just to run through the learning objectives. The first is to understand and describe potential errors in the laboratory. The second, to describe pre-analytical errors and how to identify them. The third is to understand how to describe analytical errors. The fourth is to understand how measurements of analytical errors relate to the clinical utility of results. And the fifth is to describe post-analytical errors and how to minimize them. So the pre-analytical phase, this is ensuring that the sample arrives at the analytical platform appropriate for analysis. So first is to ensure that we have the right patient. We know about the three identifiers: name, date of birth, MRN. Important to label the blood bottle at the bedside. And the other is that it's sensible, but not always feasible, that the phlebotomy label is the same as the laboratory label for lab identification of the sample. But sometimes it's worth remembering that new labels may need to be printed on arrival in the laboratory, which are compatible with the laboratory system. And obviously that's a source of where things can go wrong. So once we've got the right patient, we need to ensure we have the right sample type. And everyone's aware that different samples require different types of sample tubes. But in terms of what the actual sample is, we'll just run through these quickly. So whole blood often would use a lavender top or a green top. These samples don't require centrifugation and they're analyzed as taken. Good examples: an ABG or a VBG or a full blood count. Plasma, again, can be taken in purple top or green top, and it's the yellow fluid that can be separated from whole blood by centrifugation. Now, centrifugation involves spinning blood samples at really high speed, and the centrifugal force separates the components based on density. So the red cells fall to the bottom, and the fluid component sits on top. So the plasma can be separated from the red cells or from the cellular components and analyzed separately. Parathyroid hormone is a great example. So serum, often in the gold top or the red or rust top, similar to plasma, except that the blood has to clot first. This means that the fluid largely doesn't contain the clotting factors, and this distinguishes serum from plasma. Most routine biochemistry tests use serum, and importantly, it's not possible to distinguish serum from plasma just by looking at the fluid. So it's important to make sure that you're using the correct sample. The classical example of using plasma instead of serum gives you an extra band on protein electrophoresis, which represents fibrinogen in the sort of early gamma or late beta region. And we'll go on to this more in a later lecture, but it can look like an M protein in myeloma. Now, I focused very much on blood samples and going forward on blood samples, but there are also lots of non-blood samples that the laboratory deals with, and things like urine bottles can have acid preservatives or can be plain. So once we have the right patient and we know the sample type, we need to know the right blood bottle additive for the analyte that we're going to be testing. So the additives in the tubes are actually labeled by blood top color, and we all know this and have seen these before. So just to go through exactly what additives are in which top. The purple or the lavender top, this is classically for full blood count, contains EDTA, which chelates calcium, so it removes calcium or calcium activity from the blood. And calcium is required for the activation of a number of clotting factors, thus it prevents clotting. Now, the additive is actually potassium, 2 or 3 potassiums per EDTA molecule at a concentration of around 200 millimoles per liter. So the gold top is next, a serum separating tube, the classical routine biochemistry tube, so renal function, bone profile, liver function, CRP, and more. Silica particles are present in the gold top tube, and that encourages clotting via the intrinsic pathway, so the blood is allowed to clot. So this is used for serum. There's also a gel at the bottom of the tube that has a density in between serum and red cells. Thus, it rises on centrifugation and physically separates the red cells from the serum. The red top is up next, or the rust top, which has no gel in it. And this is because some analytes can be absorbed into the gel if used, such as drugs. Next up is the light blue top, which contains sodium citrate. So 3 sodium molecules per citrate molecule. The citrate is what binds to the calcium here and blocks the clotting cascade, similar to EDTA. But the block on coagulation is actually more easily reversible than with EDTA, which is why it's often used for clotting studies. The grey top has sodium fluoride and potassium oxalate. And the oxalate is what chelates calcium, preventing clotting. But the fluoride actually inhibits enolase, one of the enzymes of glycolysis, and prevents cellular glucose metabolism. This keeps the glucose and the lactate levels true to the patient, not to the blood cells still metabolizing in the tube. The dark green top, sodium or lithium heparin, contains heparin, a natural anticoagulant that acts via antithrombin 3. This can be used for whole blood or plasma via centrifugation and avoids the chelation of calcium or other ions. So to give some examples of why you might choose one tube over the other, obviously you might choose one tube over the other if you require serum or plasma, but some other things so that will also become a little bit more apparent later. So if you, serum or plasma will be required for most light-based or spectrophotometric procedures, because whole blood will naturally reflect and absorb different wavelengths of light, so you won't be able to separate out your analyte of interest. Glucose and lactate will have to be measured in the grey top, and I've already explained that the blood sample will effectively give results related to the anaerobic glycolysis of any of your cellular components if you don't inhibit glycolysis. And the third is that EDTA, we've mentioned, binds calcium, but it also binds other divalent cations as well. So it binds things like magnesium, zinc, iron, and lead. So if you get any EDTA contamination of your plasma or your serum, it will lead to falsely low levels of those analytes if tested. And calcium EDTA is sometimes used clinically in lead poisoning for this reason. So this leads quite nicely onto why the order of draw is important. And it's often forgotten, and I'll quickly cover it. So first is blood cultures, aerobic, then anaerobic. Then sodium citrate, which is typically your blue top for clotting. And sometimes ESR is also undertaken in a black top tube with sodium citrate in it, which is why you sometimes see ESR written here in the order of draw. Then serum rust or red top with no gel, then the serum gel, the serum separating tube, the gold top, then lithium heparin, the dark green, then potassium EDTA, the purple, group and screen, which is again potassium EDTA, and then fluoride and oxalate, the grey top, comes last. Now, does the order of draw actually matter? And it does, because there are some classical laboratory issues that are encountered when the order of draw is wrongly undertaken. And you'll come across these on a sort of at least weekly basis, probably. So the most common is probably taking the potassium EDTA before the serum sample. Now, if the concentration of potassium 2 or 3 EDTA in the additive is around 200 millimoles per liter, then the concentration of potassium in the additive is around 400 to 600 millimoles per liter. So even the smallest contamination of the vacutainer needle is enough to falsely elevate the potassium in the serum sample, and this is known as pseudo-hyperkalemia, falsely high potassium result. Now, it can also sometimes be picked up by looking at other ions that might be chelated by EDTA. So you can see low calcium, low magnesium, low ALP activity. The low ALP activity comes from the fact that zinc, Zn2+, is required for its activity. And some studies have actually shown that you can see hyperkalemia if you use an incorrect order of draw, even if the EDTA is completely undetectable in the serum sample. Another that is less common than the potassium EDTA is sodium citrate contamination. Now, you remember that sodium citrate comes at the top of the order of draw, so it's less likely to occur due to the order of draw, unless someone fills up a blue top and then pours it into another blood bottle. Where you do see it more commonly is actually with central lines, patients with central lines, because sodium citrate, sometimes called Citraloc, is used to anticoagulate central lines. And if people use the central line to take some blood from a patient, they cannot get rid of enough of the Citraloc, and then you get contamination of the sample. Now, typically what you see is an abnormally high sodium with a normal chloride. Now, the other thing that you can do if you suspect this is that you can actually run an osmolality on the sample. And what you'll find is that you get a negative osmolar gap. Your osmolar gap being your measured osmolality minus your calculated osmolality. Therefore, your calculated osmolality being greater than your measured. And this isn't seen in any other clinical situations. And the reason for it is that there are 3 sodium ions for each citrate ion. And that's why your calculated osmolality, which is 2 lots of sodium plus urea plus glucose, is falsely much higher than expected. Now, choosing the correct blood bottle and using the correct order of draw are really important, but samples also need to be handled correctly, both in general, and there's also some specific measures for each particular analyte. So in general, just thinking about delay and separation of serum from whole blood. So following blood collection, we know that the cellular components in the blood sample continue to utilize glucose in anaerobic metabolism, and this maintains electrochemical gradients and cellular functions for some time. However, over hours, these mechanisms will start to fail. The sodium-potassium ATPase, which maintains a high extracellular concentration of sodium and a high intracellular concentration of potassium, will fail, and the extracellular potassium will begin to rise. With failure of membrane potentials, cellular membranes become more permeable and phosphate starts to leak out, raising the extracellular phosphate concentration. And for that reason, labs sometimes automatically do not report results if the delay between taking the sample and the separation is more than 8 or more than 12 hours. But often the collection date or time on samples may be unknown, and so you start to see patterns that look like this that are reported for patients. Now, interestingly, the weather actually has an impact on the presence of pseudo-hyperkalemia in primary care. So in cold weather in winter, samples transported can tend to have higher rates of pseudo-hyperkalemia. And this is because the cold weather actually reduces the activity of the NAK ATPase. And in warm weather, you see the opposite. The other thing that sometimes I've been called about in the past is uncapped samples. Now, if it's left uncapped before analysis, it can be human error or a failure of an automated device, then pure water from the sample will evaporate. And what you'll get is a raised concentration of the components of the sample that are left. So you tend to see a raised sodium, a raised chloride, a raised albumin, raised total protein. Now, this can also be seen physiologically in severe dehydration, but understand or realizing that a sample was left uncapped, and also thinking about the patient location, so if they're an outpatient, and also the clinical details on the sample can help you identify that. But thinking about more specific analyte handling, is really thinking about how stable the analyte that you want to measure actually is. Now, some analytes are metabolized or broken down really quickly once they're removed from the body, and special precautions are needed. I'm sure we all remember trying to have to get a sample rapidly to the lab on ice if doing something like an ammonia when we're a foundation year 1 doctor. Now, when we get samples that where the analyte is metabolized or broken down really quickly, we can either run them straight away, and that's what we tend to do with ammonia samples, or we can freeze them to sort of -20 or even -80 degrees to be analyzed later. And it's worth remembering that one of the roles of the lab is to do stability studies, to know how samples are affected by both storage and time, so that we can confidently store the samples and undertake further tests at a later date. The other thing to say is that it might be that when samples are received in the lab, there's something that we can add to the sample to maintain its stability. And for example, for some urine samples, so for example, oxalate, urinary oxalate, by acidifying the sample, you reduce ionization, and that prevents crystallization out. Another thing that can be mentioned is that saliva samples require freezing then thawing to precipitate proteins that precipitate out the glycoproteins prior to analysis. So, in summary, the pre-analytical phase of testing should not be overlooked. It's essential that the laboratory manage and react to these requirements, and to ensure that there's minimal impact overall on producing valid test results. So we've spoken about pre-analytical, and now I'll move on to discussing the analytical phase, which is actually running the sample on the analyzer and obtaining a result. So let's start with the basics. When we measure something, our analyte of interest, we either quantify how much is there or qualify is there at all. So quantification means assigning a value. There are 135 millimoles of sodium per liter. And qualification is more binary. Is beta-HCG detectable or not? Sometimes we also use semi-quantitative methods, low, medium, high, which will fall somewhere in between those two. So I'm going to move on to giving you a typical analytical problem. We have a huge container of 1 million sweets. You need to find out how many are blue. Just think for a moment how you would go about doing that. So one way we can do this is to count every blue sweet. This is what would be called the definitive method. It's accurate, but time-consuming. These methods are also called reference methods because they set the standard for all other methods. In clinical labs, though, we don't have time to count everything individually, so we need an easier way. We move to methods that are quicker, but still reliable. And I will mention that naturally there are some reference methods that are quick enough to be used in the laboratory, such as the hexokinase method for glucose estimation, and also that reference methods may not exist for some analytes, so this becomes more tricky. But let's take a more practical approach. Let's take a shortcut. You could scoop out a sample of sweets, count how many are blue, and then multiply that by the number of scoops needed to fill the entire container. But as we all know, sampling isn't perfect. Each scoop could vary slightly in the number of blue sweets. This leads us to the concept of imprecision. If you repeated this sampling process 30 times, you might get slightly different numbers each time, but on average, you'll get close to the true number. So here's an example histogram for if you repeated this sampling process 50 times. This is like repeating the same measurement on the same patient sample 50 times. You can see that there is a central most common value and a spread of values around this. And naturally, we measure molecules per volume to remove the need to multiply up to get absolute values. So we measure in millimoles per liter rather than molecules or millimoles, but the example still holds. Now, you may recognize that this looks like a normal distribution. And this is because sampling from the same population 30 times, at least, will give estimates that fall around and approximate to the mean or average value, called the central value, for clarity. Now let's remind ourselves of the normal distribution. Use probability density rather than number of observations on the y-axis, because this is an assumption of what would happen if you continued sampling, like in the previous distribution, an infinite number of times. The distribution has two key parameters, and parameters just mean descriptions of the data. The first is the mean, the central value, and the assumption is that the central value is the mean or the true value of the result. The other is the standard deviation, and that's a description of how far from the central value the sampling observations can be. And remember that 68.3% of sampling values would be contained within one standard deviation either side of the mean. Two standard deviations either side of the mean would encompass 95.4% of the observations, and at three standard deviations, 99.7%. When you get to four standard deviations, it would be nigh on 100%. So if we go back to our example, we know that the distribution of values around that central value give you an idea of how far off any particular sample result could be. And by definition, if we repeated it an infinite number of times, 95% of values would sit within the mean plus or minus 1.96 times the standard deviation. Where did I get 1.96 from? That's because it's 95.4% within two standard deviations. For 95%, it's 1.96. And I'll show you that here. So this is the 95% confidence interval. All of your observations will sit, or 95% of your observations, if you repeat it an infinite number of times, would sit between this value here and this value here. And this is the sort of 95% confidence interval with a central value, which you're assuming is the real value. In some reports and information, 1.96 or 2 is often described as a coverage factor, which is effectively what you multiply the standard deviation by to give you a range of values that your estimate falls within. The key to all of this is to remember that when you run a patient sample, you only run it once and then give a result. You don't run it 30 times to get a good estimate of the central value. And so knowing how imprecise your method is, knowing what the standard deviation is, will give you an idea of how far away from that central result your single observation could be. Now, should we run all samples more than once? Do them all 5 times, let's say, to get a good idea of what this central value probably is. Now, although that would work, it's time consuming, too expensive, and not useful for sort of high throughput in the laboratory. Now, although standard deviation is a good measure of how much error a particular sampling procedure can have, it doesn't describe how much error might be associated with the result in understandable terms. Now, let's assume that we have a patient sample and we repeat it a number of times, and the central value comes out at 80 micromoles per liter. If the standard deviation sits around 40 and we use a coverage factor of 2 to get a 95.4% confidence interval, we will know that if we will be sort of 95.4% confident that if we run this test on the analytical platform, we'll get a value of between 0 and 160. Now that's unsatisfactory. We need to know if someone's creatinine has risen above the upper range of around 100. We need to know if someone's creatinine has risen up by 26 to diagnose an AKI stage 1. And we definitely know that there's a very distinct clinical difference between a creatinine of 150 and a creatinine of 10. Now, let's consider a creatinine result or the same thing where the creatinine result is 600 and the standard deviation is exactly the same at 40. This sort of confidence interval for if we ran the test once on the analytical platform would sit between 520 and 680. Now, clinically, this is much less ambiguous. It represents end-stage renal failure. I'm not suggesting this is ideal, but it's less ambiguous. And so we often use coefficient of variation. Now that's the standard deviation divided by that central value multiplied by 100, so it's measured in percentage. And just to put that into context, if we do that with our result of 80, you get a coefficient of variation of 50%. For the second example, you get a coefficient of variation of 6.67%. Now this is better, this is probably a better representation for 2 reasons. So it gives you more information when comparing to a clinical decision, and it's often possible to describe what's acceptable in terms of coefficient of variation. So you could say that it's acceptable to have a 7% coefficient of variation here because it won't change how you act on the result. But we know that a 50% coefficient of variation around this level wouldn't be acceptable because it will change how you deal with the result. The other thing is that it allows comparison between different concentrations. So obviously, not every sample you take is going to have a central value of 80. So it's an analytical range. And sometimes as well, but not always, the coefficient of variation when you calculate it like this will actually be the same along the entire measurement range, but not always. So in our analogy, imprecision has come from a few extra or less sweets or molecules in the sampling pot. But concentration measured in a sample shouldn't always be affected by this because it's done by concentration, so per liter per volume. So where does this imprecision come from in analytical methods? Why do you get different values if you run the same sample twice? So the answer to this is that there are small temperature fluctuations affecting performance. It could be tiny volume changes of reagents or sample. Electrical noise in the analyzer, so the output of the analyzer doesn't sit completely at baseline at 0, and therefore changes can give slight different concentrations, and also random changes in reaction conditions or reagents. So if we return to the sweet pot analogy and we've taken 30 samples, obtaining estimates of the number of blue sweets, we obtain this central value that we suggest is likely the true value of sweets in the big pot. And our estimates all seem to converge around this number with a fixed standard deviation. If we were then to count the number of blue sweets in the big pot, i.e. the reference method, we may find that the real number is equal to our central value, and thus the central value is the true value. Or we might find that the real value, as I've drawn here with a purple dotted line, is the true value, and therefore it's different to the central value that we would expect looking at our normal distribution. So if it is different, it suggests there's bias in the method. Perhaps our pot captures 20 less sweets than would be expected for the volume it's supposed to hold. So the central value is biased away from the real value. So comparing a method to the reference method is one way of estimating bias. And if you estimate bias, you can also theoretically correct for it. Now, where does bias in a method come from? Might be a natural limitation in the method itself, might be a loss of analyte or fluid in the preparation steps, might be due to incorrect calibration, and it might be due to calculation errors. So accuracy is often poorly described, but it's simply how close a measured value is to the true value. So it's dependent on both the precision and the bias of the analytical method. When we run a sample once, the accuracy is the most important. Now consider this, where the green line is the true value and the red line is the central value if we were to run the particular sample a number of times with a fixed standard deviation and a central value. If we run a sample once, we may get a result that sits anywhere along this blue curve. Obviously, more results, the results would be more likely to be within one standard deviation of this central value, but 95% would sit between 1.96 times the standard deviation. And if we think about the accuracy of this, yes, this result might be quite accurate and close to the true value, but most of our results are actually quite far away from the true value. Now, if we reduce the imprecision, so we have a method that has a lower standard deviation, all of these results are much closer together, but they're still not particularly accurate, unless we also minimize the bias to improve the accuracy. So this is often defined in terms of total analytical error, and it can be estimated as follows. Total analytical error equals bias, so a calculated term for bias, plus 1.65 times the standard deviation to give you an imprecision value. Now, why have we switched to 1.65 rather than 1.96? And that's because the bias is on one side of the mean here. So the 95% confidence interval is just on one side of the normal distribution. So rather than 2.5% on each end, taking all the 5% from here, and that's where the 1.65 comes from. Now, measurement uncertainty as a theoretical concept describes all the reasons why a measured value might not represent the true value, and this extends into pre- and post-analytical factors. But newer definitions of measurement uncertainty are starting to relate to just analytical error and can be estimated or given a value which is confusingly not the same as total analytical error. So the International Organization for Standards defines measurement uncertainty as a parameter that describes the spread of values that could reasonably be attributed to the measurand, and newer doubt about the true value of a measurand that remains after making a measurement. So measurement uncertainty calculations will again give you a standard deviation around the result, and you're supposed to take all the components of uncertainty within this. So not just analytical imprecision. If analytical imprecision is here as the blue normal distribution curve, measurement uncertainty would be wider than this. And you could multiply the standard deviation by a fixed point to give you a 95% confidence interval again, for example. Now, bias isn't included in this calculation, as the thought process is that calculated bias should be either minimized or corrected for. But how you've decided to minimize or correct for your bias would come with an imprecision, which would be included in this. Now, there's some debate to the merits and drawbacks of both methods, but they do produce different things, the total analytical error and the measurement uncertainty. And I won't go into it any further than that for now. So far, we've considered a single sample where the concentration has been the same. But I want to consider a graph of true concentration of an analyte drawn against the measured average concentration in your assay. So knowing the true concentration, we would have to have done, let's say, a reference method or a definitive method, and then have a different analytical platform that's giving us a measured concentration. And we've done this a number of times, so we've got an average, so a central value. If our line here runs at unity, so y equals x, so for a true concentration, you get a true concentration of 2, for a concentration of 8, you get a true concentration of 8. Then there's no bias between the methods. But if the line diverges from unity, so it starts off at unity, but then diverges, then then there's a proportional bias, and this means that there's more bias in the method as your concentration, or as the true concentration, increases. And you can describe that proportional bias with y equals mx, where m would be the term that describes your proportional bias. This is how I drew the red dotted line. If there's a bias that is the same at all concentrations, then we call that a fixed bias. So obviously the distance between the unity line and your analytical line would be fixed, and that can be estimated as the plus c term in y equals x plus c. Now, let's assume that we have an analytical platform that where the average measured concentration runs at unity with the true concentration, suggesting that there's no bias in the method. If we were to, so the shaded part here, I've included to show the standard deviation. Of the analytical method at each concentration. So on the y-axis. Then you can see here that the standard deviation increases as the coefficient of variance, the standard deviation increases as the concentration increases. If I then correct this into coefficient of variation, so I divide the standard deviation by the true, or by the average measured concentration, then this is what would offer you the coefficient of variation. And you can see that this is how the coefficient of variation might be fixed for the entire analytical range, effectively. Obviously, this isn't always the case. Your coefficient of variation won't always be the same at all different concentrations, but it's a possibility with certain methods. Sorry. So one reason for methods to work less well than a definitive or a reference method are matrix effects. And these are components of the sample other than your analyte of interest, hence the matrix that it's contained within, that interfere with the measurement procedure. Now, for example, imagine that all of your sweets are stuck together. It would make it really difficult to count the blue ones. Now, it's important to minimize matrix effects in analytical chemistry, and a sort of simple example is centrifugation. It removes all the cellular components that can interfere with the sample. Now, matrix effects produce interference in a measurement, but interference is generally reserved for specific substances or components that are present in the sample that can affect the measurement of the analyte. It might be helpful to think of matrix effects as the sum of all the small interferences that may also interact with each other, i.e. it's not just a sum of the parts. And a specific interference is when a singular molecule or compound or component exerts a significant effect on the measured result. Common interferences are hemolysis icterus, which is the yellow discoloration of fluid because of bilirubin, and lipemia, which is the sort of milky white discoloration from lipids or proteins, are really the classical interference that we think about. They especially affect light-based procedures, and we'll talk more on this in later lectures. So just to finish off the analytical sort of section of this talk, when we're thinking about analytical methods in terms of their clinical use, it's helpful to define how much error we are happy to be associated with a particular result where it won't significantly affect patient management. For example, we might define that the coefficient of variation that's acceptable for creatinine is 10% along its entire measurement range. Now, this would be known as an analytical performance specification, and these are agreed by expert consensus. And there was a conference in Milan in 2014, an EFLM conference, that defined a hierarchy of evidence, or updated a hierarchy of evidence that should be used to define these analytical performance specifications. And the first is clinical outcome studies, where you actually investigate how people or how the effect of results actually change clinical management. And that's the gold standard in this. There are also models that you can use based on biological variation data, come on to that at a later point as well, and goals that might be based on best other data, so professional consensus, EQA, professional organizations defining them. Now, these can all be defined in terms of maximum measurement uncertainty or total error allowable, which depends on whether you're using measurement uncertainty or total analytical error calculations. And just remember that TEA is total error allowable, and it's different from total analytical error. So that's the sort of end of what I want to say on the analytical phase. So we'll move into the post-analytical phase, and this relates to the handling of the raw analytical results through to communication to requesters, and it may even relate to management decisions. So I'll just talk through a set of things that are worth thinking about in the post-analytical phase. I think often it's not thought about as much as the other two areas. So the first is data entry errors. So when transcribing results, you can get transcription errors, especially when results are manually entered into electronic systems or reports. So if it is being done manually, it might be worth thinking about minimization mechanisms, such as having a second person review the data to make sure that they've been inputted correctly. And obviously we're moving towards automated checks, where there's automated systems for data entry to reduce things like human error. Next up is reporting errors. So first of all is thinking about complex reports. So some tests, and I've used protein electrophoresis as this example again, don't provide raw data, but rather summarized results. And in this case, laboratory staff must interpret and report the findings accurately. And there's obviously a risk of error in this that can lead to significant patient management errors. So we have very clear training pathways, competency frameworks, robust documentation, and all of that is critical to ensure that reports are accurate and reliable. In some instances, labs may also choose to report abnormal results or patterns, even if the report wasn't explicitly requested. And this practice is there to help guide clinical decisions, but should be done very cautiously. Caution often because there's incomplete clinical information. Often lots of requests come to the lab with very limited or minimal clinical context. And we know that biochemical results are not the sole basis for patient management decisions. So it's important for labs to strike a balance between what is helpful and providing too much information. It's key that results should be clearly communicated out, and definitely to include signposting for requesters to be able to contact the laboratory for additional guidance going forward. Naturally, delayed reporting and releasing of results can cause significant patient harm, especially if the result is really critical for an immediate or short-term management. We know professional bodies like the Royal College of Pathologists have set guidelines on results that must be called out urgently because of their immediate clinical impact, for example, hyperkalemia. But even results that aren't defined as urgent, that have significant delays, can lead to treatment delays, can worsen patient outcomes, and even cause preventable harm. Next up is just thinking a little bit about incorrect interpretation of results. And as I mentioned at the beginning, that once results are outside of the laboratory, the interpretation of them is generally outside of the laboratory's control. But because of that, it's important that labs still play a role in ensuring that results are understood and used correctly. So should actively engage in identifying potential interpretative challenges, and provide education or guidance to non-laboratory based clinicians when needed. And it's really important to collaborate to maintain clear communication with clinical teams, especially in really complex cases. I think it's important that labs are actively involved in education as well. So the post-analytical phase is just as crucial as the analytical and pre-analytical phase. And so that sort of leads me to the end of the talk. I just wanted to say, so variation or error in results can come from pre-analytical, analytical, and post-analytical factors. Bias and imprecision are two features of analytical methods that can affect the accuracy of results. And identifying and reducing all of these errors enables accurate results that can be used for clinical practice. And that's the focus of the talk. So what next? I'll cover the sort of qualitative considerations. Obviously, I'm very much focused on quantitative here in the fourth lecture. There's a lecture on IQC and EQA quality control next week. And please do feel free to email me if you'd like. Well, I'll move on to questions in just a moment, but I just wanted to tell everyone here about the FRC Path Masterclass. So it's on the 10th of December 2024, so this year, and it's going to be at Glenister Lecture Theatre at Charing Cross Hospital, which is next to Hammersmith and Barons Court Tube Station in London. It's £1 if you come in person and £5 on Zoom, and there will be lunch provided in person. We've got some great speakers from consultants on T3, mass spectrometry, GLP-1s, inherited disorders of metabolism, lipids, immunoassay, and neuroendocrine tumors. And there's a QR code here where you can sign up. So please do. So that's all for me. If you